Welcome back. It's the new season of the Transformed Mind, and we're so happy that you're here today. This is the podcast where we're exploring the real world intersection of mental health, addiction, and transformative care. I'm your host, Dr. Owusu. Most people call me Dr. O. In each episode, we take a thoughtful, practical, and evidence informed look at how we can improve psychiatric and addiction care from clinical settings to community spaces. If you're new, here's the vibe. We have the host RX, where it's just me and you. We delve into the research, we share what we know with each other, and the work that we're doing that actually matters. And then we have our expert RX, where we bring in brilliant minds from the field, whether it is a clinician, researcher, change maker, policymakers. We bring them here and they share their expertise with us and they teach us. And we have our lived RX, where that's the real world stories that come in. Guests who have lived it, they have survived it, and reshaping the system because of that. Today is a very special episode. We have an expert episode, and I'm glad you're tuning in with us. It's a special month of February, and we're starting it off very strong with something that's very dear to a lot of us. If you're listening, that's because you care for your communities, the people that you meet on the streets, the people that walk into your clinic, the people that you see in your hospitals. It could be a family member, it could be a friend. We care about these people. This episode is going to tackle an issue touched home for a lot of us. It's going to be grounded in a longitudinal study that was published in Drug and Alcohol Dependence titled Return to Illicit Drug Use Post-Incarceration Among Formerly Incarcerated Black Americans. And if you know anything about the history, this month is a very special month. So we are happy to be starting off with a topic that is centered around our Black men. Before I introduce our guest today, I want to ground us in 3 evidence-based facts from the literature that we're going to be discussing today. And from this study, we see that recent incarceration independently increased the odds of illicit drug use among Black Americans, even after controlling for a prior substance use. It also shows us that incarceration was associated with increased heroin, cocaine, and polysubstance use, not just the reduced use. The association between incarceration and drug use also persisted after adjustment for income, education, mental health, and neighborhood context. So all this is saying is, regardless of how much money you make, how much of an education, your mental health status, what neighborhood that you live in, there is an association between drug use and incarceration. So these findings really challenge the assumption that incarceration stops people from using drugs. It also asks a very critical question. Does incarceration itself actually change substance use risk, or can it become a risk? So joining me today, we have a forensic and addiction psychiatrist whose clinical and research focuses on justice-involved populations. We have Dr. Jason Barrett. He is an early career psychiatrist and community mental health provider from Southern California. He has a clinical assistant professor appointment with Charles R. Drew University College of Medicine. He also serves as an associate residency training program director. He also serves as the psychiatry clerkship director in the Department of Psychiatry. Dr. Barrett earned his Bachelor's of Science in Nursing at Marymount University, shout out to the DMV area, and his Doctor of Medicine degree at St. James School of Medicine. He completed his psychiatry residency at Charles Area Medical Center in West Virginia. After that, he completed 2 fellowships, the first in forensic psychiatry at the University of Cincinnati College of Medicine and addiction psychiatry at Indiana University School of Medicine. His committee participation, presentations, and professional membership has spanned both local and national levels. So please join me in welcoming Dr. Barrett, the amazing forensic and addiction psychiatrist.
Thank you for having me. I'm humbled by that introduction for sure.
We're so happy to have you here today. In this episode, as we mentioned, we're going to be exploring the evidence and what it actually shows and how clinicians can interpret symptom recurrence after incarceration. And if there's a policymaker that may be listening, what are some things that they could possibly do to help? And if it's a community, member, what are some responses that are supported by data that they can use to help their family members or themselves? And the central guiding question for this discussion is going to be very simple, but profound. And all we want to understand is if incarceration is meant to deter drug use, why are some studies suggesting that sometimes it does the opposite? What are your thoughts?
Yeah, I kind of reflect to before I worked in the carceral system. I used to have the mindset where if people go to jail or go to prison, they're not going to use drugs. And I quickly found out that is not the case. In fact, I've had patients tell me the first time they ever used substances was when they were incarcerated. Imagine that. So I think there's a lot that goes on behind the walls that people are not aware of. But if the central premise is to lock people up to help them abstain from using drug use, it's a false hope. So we got to all open our eyes on different levels to come to the awareness that is not true.
That's very interesting because sometimes I feel like most of what we learn or even get out of our clinical work, we learn a lot from the patients that we see. I learned from their experiences or how they feel when they take certain things. So I think it's great that through your experience, you've been able to meet people that has changed your perspective on how they feel or what has happened or what their experiences have been. Do you think there's anything that we can learn, let's say, other providers that are not in the forensic field? Is there ways they can find this similar information or experiences?
Yeah, I think being inquisitive overall is the key, and inquisitive with a sense of just wanting to understand people's journey. You can ask questions and try to be nosy, but a patient senses that. When you ask these questions, you're really just trying to understand how it plays into their overall care. And I think more patients than not are willing to share that information because some of them know we haven't personally experienced perhaps what they've experienced. And the whole hallmark of the mindset is to allow me to deliver better care for you. So if you can't be transparent that, yeah, while I was incarcerated, I was using that helps to guide your care as you transition to that outpatient world if you're not providing the treatment behind the walls.
Definitely. I think what I'm hearing is rapport building, which is one of the fundamental things that were taught in medical school, or even just in general, knowing how to relate with people. And one of the things I've learned myself is I always say, as psychiatrists, we're like FBI agents. You're always finding information and piecing them together. And that's literally what you just said. Just that curiosity can go a long way asking questions. So if you're listening and you're like, but I'm not a forensic psychiatrist, you need to ask some questions. You may find some of the answers that you're looking for. Do you have, as a clerkship director, do you have any advice for medical students or residencies that may be interested in the field, but are a little bit shaky because they're like, I don't know, it may be dangerous? Because sometimes you hear those things where people can stay even away from psychiatry in general. My family was a little skeptical about me going to psychiatry. They asked me several times, are you sure this is really what you want to do? That's the population you want? So, you have any advice for any medical students that are interested or trainees that are trying to decide what subspecialty they may do if they do any?
Yeah, I think every specialty comes with risk. Unfortunately, we're seeing, especially even in the ED, there's an increase in violence amongst patients as it relates to nursing and doctors. So no matter where you go, this level of risk is going to be enhanced. I think we all just have to use basic principles of safety no matter where we go. But I would encourage that medical student that's thinking about psychiatry, if they feel the specialty lends itself to them connecting with a patient, I think this is the right place. Unfortunately, sometimes in medicine, there's a lot of emphasis on the go, go, go. But I encourage medical students to use our clerkship as a time to really dive into a patient's story and connect with them. The only fault I would say for a medical student is if they've taken a lot of time and bring back no information. Very rarely are clerkship or site director is going to get on the student for spending too much time with the patient. This is probably the only specialty where they won't be dinged for that. But if you spend a lot of time and come back with no information, then we have a problem. So if they want to really connect with patients, I think this is the place that they could do that. There are probably arguably some other specialties, but I'm going to say psychiatry takes the cake in that vein.
And I'm definitely agreeing with you on that. I fell in love with it, and I don't think I could do anything else if not for psychiatry. And it's so funny because I was just traveling in Ghana, and I helped teach in medical schools there. And I was telling them, like, you just spent 2 hours and you still don't even have a differential diagnosis. Something is off.
Yeah.
Like, you have to have something.
When a
So
patient says, long story short, I say, no, give me the long version. I have time. I want to hear the long version. Yeah.
definitely. And I always say there's always a story behind the diagnosis, the person. And I want to know that because it gives you more information about who the person is and it could possibly help in your treatment plan.
Yeah. And in accordance maybe with what we're talking about here with the substance use, I think it's important that we at least familiarize ourselves with substances or names of substances, maybe some slang terms that are used for certain substances. It helps to get information. You don't need to know maybe every slang term. There, you can't keep up with all, right? You could actually do a study on the amount of slang terms for every drug that there is, but be familiar with some of this stuff, especially in your local area. It's going to change depending on what county you're in, what state you're in, but be familiar with some of these terms because that's when a patient may, oh, yeah, I do use that versus you using some scientific name or classification or category for a drug. So, yeah, being inquisitive goes a long way and really listening. I would take that all of us working in this mental health space are listening to our patients. And if a medical student is keen on doing that, I would encourage you to come to psychiatry, particularly interview at our CDU residence. Shameless plug.
Yeah, and you can plug it all you want. Yes, because we need more psychiatrists. So please. And it's a great program.
And even further apply to the medical school. Another plug, but go ahead.
No, definitely. And this is mostly I do this at the end of the segment, but since you're talking about it now, I think this is a great opportunity to ask you to do a mini crash course for our medical students or even trainees, because addiction training is not really embedded in our curriculum as much. We only supposed to do 1 month of it. So area medical center in West Virginia. If you could give a crash course of some of the most common drug names that you think we should know, because sometimes you ask someone, they'll say no, because they probably just have a street name for it. And then if you can highlight the ones that are very common in your area.
Yeah, the one that I've come across more often, cocaine or crack is pretty mainstream. Meth is or ice, crank is pretty mainstream. But the one that tripped me up early on here in California was the hallucinogen that they were terming as SHRM. PCP, the scientific name, if you will. I remember growing up, people used to talk about the Dipper and the DMV, and it seemed to maybe have this reemergence here in California if it ever went away. But you say you use any PCP, you use any hallucinogens, you get no, you use any SHRM. Oh yeah, I use SHRM. And that helps you, especially when we're trying to treat things like psychosis, to identify where this is really coming from. Is this organic in a sense, or is it attributed to maybe substance induced psychosis? Yeah, like I said, there's a long list of street names for different things, but the SHRM in particular is something that I see most often here in California that would be most relevant to my practice.
Definitely, because I've actually never heard of anyone call it that. So I'm learning. This is the first time I'm learning it.
Yeah.
Now I know. Sometimes I'm asking people, "You use PCP?" And they're like, "No."
Yeah. Wet
I need to.
can be across the board. If you say wet, you use wet. Yeah, but yeah, SHRM, I still don't know the origin of where that came from. Maybe I need to dig into that on my next appointment, but yeah.
Definitely. I think you learn a lot more. I've learned a lot of mixes that people do, and I'm like, "Oh, I didn't realize that." But
Mm.
you learn a lot more from people. And with everything that we're talking about conceptually, this aligns with like the framework of vulnerability that may happen. Like this may start for them through like the environment that they're in, how they grew up, housing, like all these different social determinants of health that can affect how they grow up, how they start using substances. I know one of the studies that I recently worked on was with the SAMHSA data for the past 20 years, and just looking at how social determinants of health actually influence the age of use. And it shows that most people that are using earlier on, due to social determinants of health, they're very likely to have psychiatric disorders when they're older. They're more likely to have a disruptive life when they're older. And it's really sad, but sometimes when you look at the base of all of this, it's a lot of like structural vulnerability. And incarceration is one of those things that can disrupt someone's housing, their employment, their health care, their social networks, right? So if someone was growing up and their parents were incarcerated, and they ended up in the foster care system, or they had to grow up homeless. They didn't have parents that had jobs because they're incarcerated and they couldn't get like an appropriate job. All these things affect people. And the central gap that the literature shows is there's like the lack of knowledge of all of these things and how they affect individuals, especially those that use substances, and they're not appropriately addressed in the care that they may receive. And most incarcerated individuals also actually are not receiving treatment at all. Some other data that I've looked at in the past was how many jails and prisons actually had access to medication assisted treatment for people that were actively using before they went in. And even after they're like released, that continuity of care sometimes is like lapse. So all these implications are like impacting people. Why is there like a clinical significance that incarceration can predict drug use even after you've controlled for prior drug use?
Yeah, I think there are many different angles to that. One in particular, I think it really has to do with why people use substances. And that is something I do tend to ask my patient, what is the substance doing for you? Sometimes it could be a underlying psychiatric thing that's not being treated. There's a lot of research going on about maybe the correlation or overlap with folks that possibly have ADHD using, right? Depression, anxiety. Sometimes these chemicals maybe mimic treatment that they could get that won't have their life spiral out of control. Sometimes it's an escape from the reality, maybe even PTSD trauma, right? That hasn't been diagnosed or hasn't been treated. Or you just don't see a way forward. As you mentioned, most folks or some folks have had family members with a lengthy line of incarceration, right? And substance use probably played it. And seeing that repetitively, that's what you know, right? You talk about the knowledge, never saw anything outside of this chaos or this turmoil. So that is what I'm going to go to, especially when you're starting at 11, 12, 13 years old. Then you talk about maybe the falsehood that being incarcerated stops drug use. Possibly doesn't. They're continuing to use in there. And then when they come out, they're going to go back to using. That's what they've been doing since being convicted. So I think it's many different lenses, aspects, areas as to why folks would use prior to and then even after being released.
Definitely. I think when you are looking at things from a multifactorial lens, that's very appropriate. When we just look at just substance use itself without incarceration, we know there's different biological reasons, there's psychological things. When you look at the population that most are affected, do you see any differences in the different groups, like males compared to females, ethnicity, race? How what differences are you seeing? And do you still feel like there's still that clinical significance when you look at after being controlled for prior substance use?
Yeah, I think substance use is touching everyone. It's a miss on our part if we're not asking every single person that we see about substance use to take for granted maybe the 20 or 19, 30-year-old was the one using substances and that when grandma comes and we don't ask that question because there's no way in the world I think a VA patient that I had when I was doing my addiction psychiatry fellowship. And I asked all the right questions, but he said he wasn't using any substance. But looking through the chart, stuff wasn't adding up. I'm like, this was positive, or this note said this. He said no. And maybe one or two appointments in, it finally came out for whatever reason, maybe feeling comfortable. I don't remember why he wasn't upfront from the beginning, but he was around 79 years old. I could have took for granted. I don't need to ask this question, but we need to be asking every single patient about substance use and also following up. It's not just at the initial appointment because things are going to change, right? Between now and the next appointment. Revisiting some of these questions, if you don't have time every visit to do it, I hope we would, at least making sure it is something you're doing regularly to see if there's any change going on. I would also say I kind of struggle with the point that people reach their change. I don't know if there's a certain point, but I look for that line. As I sit today as an early career psychiatrist, I do think there's a proverbial rock bottom that people hit, but that rock bottom changes for folks. And it all depends. Sometimes it's the kids that really lead people to want to make that change. Sometimes it is this incarceration. I've done this for the last 25 years and I'm tired. I'm tired of going to jail. I'm tired of going to prison. Sometimes it's secondary things related to illness. I don't know what it is, but we have to start meeting the patients where they are. And I say that not only as a clinician, but also as a society as it relates to what is supposed to be criminal justice. Maybe mandated treatment may not be the answer if they're not at that proverbial rock bottom. The question is, what do you do with these people? I think tender loving care goes a long way. Shout out to the judges that do that approach. But if a person's not ready, I think it just doesn't go far. But meeting them where they are. What do you want out of this? Where do you see life going? Seeing how I can help walk with them on that. That's what I try.
And I think that's very powerful to allow someone to get somewhere because you can't really force change. And as you're saying that, I was just going through the trans theoretical model and the stages of change. And I'm like, sure, I've seen that play out even as a resident multiple times where someone is just going through that cycle. And you're like, why is it? Because they weren't ready for change. And someone is saying, if you don't do ABC, you're not going to get D out of this. So they feel the need to do it. And then they're going through like a repeated cycle. But I've also seen when someone is ready and they actively participate in the care that they're getting, I've seen people do amazing. And I'm like, this is incredible to be able to be part of that story. So I'm with you on that. We have to meet people where they're at, especially for those people when sometimes it's just a slim window of I'm ready to do this. And if you don't catch them there, that's it. They slip out. And then it's like a whole God knows how long
Yeah,
before you can get them again. So
and sometimes patients in general, you can sense some frustration, right? But I don't know, person continues to miss appointment. You keep on putting them on the schedule. Maybe I've asked myself why, but I think sometimes in the midst of substance use, as is with kind of the severity when we're diagnosis, most parts of their life are falling apart, right? Work is falling apart. Family relationships are falling apart. Education is falling apart. Health is falling apart. I find sometimes you are that only sense of normalcy for that patient, right? Many bridges have been burned. And if you can continue to show up and be there for them, I think one day when they're ready to make that change, they can see a path forward or a brighter future because you're the only one that's still sticking with them. Mom is tired, dad is tired, grandma's tired, the kids are tired, the courts are tired. But hopefully, if you can show up for that patient yet another day, you start to see that change. You may see missed appointments go from the missed appointments to being early for your appointment. That's when you know a change has occurred. It's, oh, not only are you here, but you're early. You checked in early. We got something going.
absolutely. I remember how excited I was when I was telling my supervising attendant about a case. And before I got the case, they were sending out like letters for the individual to drop them out of the clinic. And everyone was just exhausted. And I'm like, maybe we'll connect. They're young, I'm young. Maybe there'll be some connections. I'll try. And I took on both the role of a psychiatrist and a therapist. I was like, I don't know, maybe it'll work out. And then there's a moment where he will miss appointments and they're like, you need to send mobile. And I'm like, but I know the trauma that's associated with sending all of that to the house. And I'll
Mhm.
try to like advocate. But I think, and that also would lead me into my next question. I think I could understand from the point of growing up as a person of color and interactions with just the police and all of those in general, and just knowing even from my patients that are not of color and their interactions with multiple people going into their homes, the crisis with the cops and all of that, and the effect it has on them. So I tried to avoid that, but eventually there's one day where they couldn't make it, and I said over and over again, if you can't, just please call me. So
Mhm.
at least I know that you're okay. You just can't make it. And then they called me like multiple times. I was with a patient. I was like, who is calling me over and over again in 5 minutes? And I listened and it was just this person saying, I'm sick. I know you said I should call you. I just wanted you to know. And I felt this excitement. And I was
Mhm.
telling my attendant supervisor, I'm like, that's just initiative. Like he's doing so much better. There's some insight. He called to let me know. And I'm like,
Right.
yay. So
Abs
that's the kind of change. It's like the tiny little step, but it made I was like, okay, we're making progress. We're heading towards the right way. So I
absolutely.
completely understand what you're saying.
Yeah. And in the same vein, even as I think about that, having that heart to heart with the patient, as you talked about the dismissal of the patient, are you ready? Are you not ready? Come back when you're ready. I think that's fair. Now, if they're under some court mandate, they got a hard decision to make, right? And I encourage patients to use their autonomy. You don't have to be here, but you and I know if you're not here under this court order, there's going to be a consequence. But having that heart to heart, are we ready to do this or you don't want to do this? Come back when you're ready. I'll be here. I'm not going anywhere. Knock on wood, I'll be here.
Right. Definitely. I think you can say that. As a resident, I can't because every year there's a change in residents. So
Yeah.
I can't tell you I'll be here, but someone else will be here for you. So, talking about just trauma and people of color, do you feel like, and earlier when you're talking about like the clinical significance of the incarcerated predicted drug use even after control and prior substance use, like that clinical significance, do you think there's any role that trauma plays there when it comes to like carceral trauma, racialized trauma, and just how it may play a role in like post-release substance use?
Yeah. And even the care that we deliver in general, I think a lot of our patients have some of them at least have been seeing mental health providers since they were young and probably, and I've heard from them that most of the providers don't look like you and perhaps they've been treated a certain way in those settings. And then in the carceral setting, they're treated a certain way. There's this lack of autonomy, this lack of personhood sometimes that they experience. And I tell them, even because I work with a lot of patients who are court ordered, I tell them, I'm here to work for you. Coming to you because of the court order, they see you as the them, as the enemy, right? But by nature and design, the truth is, I'm really there to work for the patient. I'm not there to work for the court. And they have to trust me on that. No information is going to be given out unless you choose for it to be given out. And I try to hold true to that as much as possible and let the patient know I'm pretty transparent about what's going on. Absolutely. I think building the knowledge base of our patients is very important. Maybe I may over explain a diagnosis, but I want you to know what you're being treated for. So many of them come to us, they've seen practitioner after practitioner. Sometimes they know what they have, and based on criteria, it doesn't make sense. Like, how can you have you it's like today I'm meeting you in this snapshot. If you don't come back, at least keep this in your mind. This is what I'm thinking, right? From the ground level. Why are you on this method? I don't know. They just prescribe. And I try to get them as a partner in this, right? I want you with all the information I've given you now to help make a decision about what you want. Some are going to defer. You're the doctor. This sense of just being secondary to the whole system, they carry that sometimes for years, starting 5, 6, 7 years old. And You get in the correctional system, you're being told when to go to sleep, when to eat. You know what I mean? It's different. Having that autonomy again. So I urge patients to embrace that and to really be a partner in their care. We don't have to agree, but I am going to give you the best clinical judgment, and I'm not going to do anything that I feel is unsafe.
Absolutely. And thank you for what you're doing. I think you're doing such important work. So, for the people that don't know, I should have done this in the beginning. I think a little bit of terminology lecture maybe really go a long way. So if you can tell us what it means to be a forensic psychiatrist, what the role is, what it means to be court mandated treatment, like all those things. So if anyone else is listening that's not a clinician or a mental health professional or even in the judicial system, they can have an idea of what we're discussing.
Yeah, so a psychiatrist, by definition, goes to medical school, is a mental health provider versus a psychologist that doesn't go to medical school, but psychiatrists study medicine. So when we're treating patients, primarily we use medication. The forensic psychiatry is extra training on that medical knowledge as it relates to mental health and some aspect of law. And that's broad. It could be a variety of different things, but it's some intersection between law and mental health. Now, when we talk about court mandated treatment, someone usually has some offense and they've gone before a judge and the judge has ordered them to mandatory treatment or else there's some consequence. For those now that are getting the scope, you can imagine someone who's not ready perhaps to stop using substance or not interested now being told they have to engage in treatment. So that's where that intersection is.
So would a good example be someone that was involved in like a DUI, may have a charge, and then the court is now mandating them they have to see someone like you for alcohol use disorder or like alcohol misuse?
Yep. Yeah. And that's usually sometimes it can be in lieu of a sentence or in substitute of a sentence, like a outpatient type of thing. Sometimes it's even after serving some time, being on probation. This would be part of the guidelines that they would have to abide.
That's amazing. So if someone is a clinician, how can they incorporate like recent incarceration into their risk assessment and treatment planning?
Once again, asking the question, I'm pretty ingrained with asking about past incarcerations. And sometimes you get responses like I did today, where he says, I don't want to talk. Fair enough. Like I'm not going to push, but I think at least knowing that there's a history of incarceration sets the landscape like we're talking about right now, knowing that, oh, substance use happens while people are incarcerated. I can now dig into that and be able to provide that comprehensive treatment. Knowing some of the things that they may experience while incarcerated, we can ask about maybe traumatic events. They may not give you the specific, which is not what I'm looking for. I'm more so looking for how the events that you or experience while you were incarcerated now affect you in your day to day. That's really what I'm looking for.
Has there been any case where you're more like surprised or was very intriguing that you might want to share with us and how it could be like a good example of risk assessment and incorporated that into your treatment planning?
I
This
think,
can be one of our other mini crush courses.
yeah, I think the only surprise is there are no surprises. But yeah, I really couldn't think of a specific case. Anything that you could think that happens on the outside happens on the inside. Sometimes worse on the inside, depending on kind of the county or the jail. There's certain parts of culture that come into play sometimes with gang affiliations and things like that. So it gets brutal. It really does. It gets brutal. And there's no shortage of maybe news feeds that deal with folks that bring in contraband sometimes that are part of the correctional system. This happens a lot. So it's very messy. It is very messy, but trying to do your due diligence is the hallmark.
What does the evidence show about addiction treatment in during incarceration?
Yeah, there's a lot of support for that. I think that as a whole, we have a lot of work to do as it relates to FDA approved treatments for the amount of substance uses that we have. There's a big gap. As it stands, tobacco and opioids and alcohol are really our hallmark FDA approved treatments, but there's so many other substances that are being used that we don't have treatments for. But as it relates to especially opioid use disorder, we have bona fide treatments for that. And the numbers show that folks that engage in treatment when they are incarcerated, they have better outcomes. Now, still, many states, I'd probably say roughly about half, still don't offer this for folks who are incarcerated. There's many different reasons to that on both sides, both the practitioner side and maybe the criminal justice side. But we need to continue to collaborate and come together because it just brings about greater outcomes for our patients. And it really does make folks' life a little bit easier. You can imagine folks that are continuing to use opioids, they're getting it somehow. And you can imagine the culture behind getting the illicit substance in the walls. If we can provide the effective treatment that we know is safe, it can minimize some of the conflict that does tend to happen as well. Conflict, extortion, all types of.
Absolutely. Earlier this year, I was privileged to work with a group on a position statement for the APA regarding treatment within the justice system. And a lot of data actually shows that the people most affected are people of color, but they're also the ones to receive the least amount of treatment or access to care.
Yeah.
What are some of the policies or the things that we could do as clinicians or as community to help bridge that gap?
Yeah, for sure. A lot of things come to mind. One, as we talked about, if you're really interested in this space, there's a lot of work to be done with pushing the needle to make sure that there's an offering for medications that we know can treat these substance use disorders. So that is always a groundwork or framework to help enhance the treatment that we give our patients. I also give kudos to patients that have taken it upon themselves to file some lawsuits. There are lawsuits that have been won now because of lack of treatment, really on two arms. I've seen it both as the violation of the Eighth Amendment. They said it's cruel and unusual that their opioid medication wasn't continued while they were incarcerated and that it was suddenly cut off. They've also filed lawsuits based on Title II of the ADA, saying that it's in violation of their disability, them having a substance use disorder and not being able to continue treatment. And they've won. Patients in and of themselves are filing lawsuits as it relates to policy and saying this is in complete violation. I would also encourage us that folks who don't work in states that use the Medicaid 1115 waiver, this is maybe right territory to start some of this policy work. California, I think, was the first state to enact this bill. Usually, when folks get incarcerated, any kind of state funded insurance is cut off, I think, after about 30 days. And then when folks were getting released, there was no reactivation of this. So it's actually two arms to this. Within about 30 days upon release, the Medicaid 1115 waiver allows it to be activated. So there's a seamless approach to the outpatient world. Right? We still get some patients that come to us after being released way after 30 days and still don't have it reactivated, but it has helped minimize that lapse, right? You see a patient, they've been out, you prescribe a medication only to find out they don't have insurance. Sometimes it causes a little bit of a hiccup. Having states hone into that can be helpful. I think there may be about 15 or 20 states now that are doing that. And actually, the waiver is broad in that there can be used or funds can be used to treat some certain things while folks are incarcerated. So this blanket thing of not having funds accessible no longer exists. So I think those would probably be maybe three areas to think about as it relates to policy.
So these are like amazing. And just now that you're saying that, I'm like, I need to look into New York to see if we have that Medicaid extension. But I'm also thinking with everything that's happening currently in our country, were any of these affected by the recent changes? So I'm like, out of curiosity, I'm like, I need to go look into all of this and see what has changed because I know I've been filling out new forms for some people that needed to change housing, all of these things. So I'm like,
Mhm.
I need to make sure these haven't been affected. And if they have, I need to use my voice and my power to advocate for patients. But through everything you're saying, the one thing that kept ringing was imagine having diabetes and then ending up in jail and not getting your insulin or your metformin or any of those medications. That would never happen, but it happens when it comes to substance use. And I'm like, okay, what could be the difference between the two? And I think it's just how society sees
Mhm.
substance use versus diabetes. And a lot of different addictions, they don't see it as an illness. They just see it as a behavioral problem. Every time I think of, I'm like, this is crazy. We need to educate more, which is part of why this podcast even came about. And at first it was targeted to fellow clinicians and trainees, but the more conversations I've had, I'm like, this needs to be open to anyone that wants to learn and make it accessible to them, even the policymakers, because obviously they need to be educated as well. The voters needs to be educated beyond it just being behavioral or there's all these different aspects to it. Can you teach the community in the simplest term that they can understand what makes substance use or any addiction similar to diabetes?
Yeah, it's really no different in that the etiology is very similar, right? Environmental factors as well as biological factors are still going to play in. The rate of relapse, if you will, is almost equitable for someone that has uncontrolled diabetes, the lifespan or the risk of that happening again when it's controlled. Same thing with substance use disorder. This goes for hypertension as well. But I would also say probably the primary care folks have some difficult time as well when they're treating patients that are incarcerated. It's just not an environment that's conducive, I would say, to the best care. The care should be equitable by law, but for it to be the same, sometimes there's a struggle. And that you also have lawsuits based on that, saying the care wasn't equitable. But we all kind of struggle with some of the resources behind the walls. And I think, or at least I hope that we all try to do our best in that vein. But life expectancy decreases all across the board when someone is incarcerated, and the rates of chronic diseases seem to increase as well, including our coronary artery disease, our diabetes, our cancers. So it's something affecting everyone. And we hopefully would put the same energy that we do into substance use disorders that we some of these other things. But I know it's difficult. It's hard. Some of the things that you may get with a substance use disorder, you're not going to get maybe with hypertension or anything else. Usually someone who has hypertension is not trying to pawn your stuff, is not showing up at 3 o'clock in the morning, disturbing the neighbors and knocking on folks' door, or showing up drunk on the lawn naked. You don't get that. So I get it. But if we could have hopefully a little bit more compassion wherever we can get it from. And that brings me to another point that I think about. Trying to do this by yourself is very difficult. I take a lot of pride in the team approach that I have with my patients, because if I tried to do this by myself, I don't know, I wouldn't last long. Having that therapist, having that case manager, there's a lot of emphasis being put on using peer specialists as well. Having that team approach goes a very long way. You have a finite amount of time when you're in that appointment with that patient, but having folks that can really get to the heart of some of the other issues you talked about. Can you imagine trying to get a job? You don't have a social security card. That ain't gonna last long, right? Trying to get a car, you don't have a driver's license, you don't know how to apply for insurance because you was always on your mom's insurance, a bus pass. You're really trying to restore people's lives. Broaden this thing outside of our 20, 30-minute, 90-minute evaluation and really getting to the heart of some of these issues is going to be even that much more important when it relates to substance use disorder. How do you sign up for college? How do you work the laptop? These are the things that some of these patients are really dealing with. So I'm proud of the work that we're doing and continue to do no matter where you are. Please be encouraged, because you do make a difference when you get those patients that re-enroll into school and are in their last semester of getting that bachelor's degree. When 10 years ago, they were incarcerated time after time, or that person that decides to go and get that peer specialist certificate to help someone else after they've come through on the other side. Those are the stories that make this work meaningful. Hopefully that inspires folks.
Absolutely. And it just makes me so excited that you talk about all of this and the importance of peer specialists. I have had the privilege of working with some peer specialists. My hospital system had launched a catch team, which includes a peer specialist, and they're piloting it at my institution. So the privilege to be a part of it and invited them. We actually have an upcoming episode where the entire team is going to sit to discuss the dynamic and the importance of it, and just watching them work and how they interact with people that may be hesitant, they may not be at that point of change, but them seeing someone that's been through it and is able to be on the other side, sometimes that even help. And I've always been my goal to work in an integrative or collaborative space where I'm able to work with everyone, including the primary care provider, to give people
Mhm,
a comprehensive care. And
mhm,
just you talking about it, and just even from the lens that you looked at, you didn't just look at it from the clinician's perspective, you looked at it from all around and how we could all play a role, and how hard it may even be for the primary care provider that may also be contributed. And from the communities that may be feeling disturbed by the people, right? What it means for someone to knock on your door at 3 a.m. or have someone show up naked on your lawn, right? We're
yeah,
all being impacted by this.
right,
So we
right.
can all work together to help create a better society for all of us. So it's very important. And I think we've talked about all these different parts. One group we haven't talked about is community based organizations and the role that they can play in helping. Have you worked with any community based organizations? And if so, in what capacity and how can they be helpful?
Yeah, I think lending your voice, your time, and your resources is going to be very important. Like I said, some folks, when they're making this transition, they're doing it blindly, never having done it before, but reaching that kind of proverbial rock bottom, having folks that they can call. As we talk about addiction treatment, there are different models that use that peer support part where you have a sponsor, if you will, right? That you can definitely depend on. Somebody that's walked in your shoes and has a good amount of years of abstinence under their belt to really help you through this process. Even thinking about peers in the carceral setting, there's been pilots where they use peers also in the carceral setting, and it has shown to have some benefit as well. So not something necessarily to be overlooked. It's something that we should really grab onto for sure. This is all hands on deck. It's our community. If we're not going to do it, other people not going to do it. Yeah. Any amount of time, any amount of resource you can really put in, I think it really goes a long way, especially as I mentioned, thinking about these patients as I'm talking to you now. I'm just glad to be a part. It's really a privilege to be on that journey with you.
No, absolutely. And I think we're very, at least for me, very appreciative of all the work that you're doing. Just for the amount of time that I've known you hasn't been a long time, but I've also know that you're not just seeing patients, you're encouraging, you're teaching, and you're an example, a representation for people that look like us and encourage us to be in the field. So it's very important. And just being you as the person being in the field and other people seeing you, they're able to relate and even open up. Cause sometimes I've had people walk in and they're just excited just to see someone that looks like them. Even if they don't know if we've had the same experiences, just because I look like them, they feel like I may understand them or I may have some shared experiences with them. And that sometimes help them relax, and other times it may not even help. There's someone that may walk in and be like, I don't want someone that looks like me, which is also completely fine. But for those people that may want that, it does work as well. So our next is actually our case presentation. It's a mini presentation of a 41-year-old African American male who was released after 12 months of incarceration for nonviolent drug offense. Prior to incarceration, he used cocaine intermittently whilst he was employed. During incarceration, he didn't really receive any treatment. And now he's been released. He has no insurance. Unfortunately, he's from one of those states that don't have any policies in place for him. He's experiencing housing instability and he returned to his neighborhood that's heavily policed. Within a few weeks, he's using heavily because these stressors have increased and he's using daily. So for our clinicians and trainees, how does the study help explain Andrea's escalation in substance use?
Yeah, I think it highlights a lot of what we talked about today, right? So getting reintegrated back into the community and getting into mental health care. If he doesn't have insurance, it sets about some limitation in your treatment plan. So making sure if it's going to take a little while for him to get insurance and you see there's a need for medication, finding out how to navigate that. As some pharmaceutical companies can buy them some time until they can get the insurance activated. But beyond medication, because I talked about it's bigger than our appointment and what we do behind the walls. I heard you talk about needing housing, having a team dedicated to that, thinking about community partners. I think the best community mental health centers have legs, right? That if they don't have the specific housing, they know where they can go to make sure that folks are not in this on the street, especially here in California. I think you're based out of New York. These are probably one of the two biggest places that deal with homelessness. It's all across the country, but having legs to your organization about where you can go. And then this rehabilitation model, you talked about community organizations. I think about one here in Los Angeles that really is focused on rehabilitation for the last 30 years, employing people to work in the kitchen that they have on site within this organization, teaching them baking skills so that they can put this on their application or resume to say, yes, I have 6 months of experience in a bakery. One of the things I'm most proud of by this organization is they do tattoo removal. We're talking about rehabilitation, right? We think about some folks that are formerly incarcerated, have the tattoos sometime right in the middle of their forehead. Maybe a bad decision when they were 19 years old. Now at 30, trying to get a job. How does that look? Free tattoo removal. It's done wonders for folks' lives. So when we talk about community organizations, rehabilitation, the role that we play and the role that other partners can play, these are the avenues to really think about. They also do GED preparation and preparing for exams from this organization, but there are others. But these are the things that are going to help restore a folks' life. If you can offer things like family therapy, if the family is at that point to try to be reunified, right? But as you mentioned in this particular case with the cocaine, there is a gap, right? I mentioned these gaps that we have in FDA treatments. There are no FDA treatments for that. So what's the best medication that we can use, and making sure that we screen for other organic things is the term I've been using, whether depression, psychosis, ADHD, whatever it is, right? So that's how I would think about that case in a nutshell, and being there for them. And then knowing that there's sometimes a lot of overlap with some of the substances, that things may be in the substance that you don't know about, right? You've been out the game for 12 months now. So that same cocaine you was using last year may not be the same cocaine. Like, we got to be careful. So hopefully they take that to heart and understand that things are vastly changed. It's been only a year, but a lot changed in a year. So yeah, being careful.
Definitely. You've answered all my questions. Just go. That's amazing. That's what we want. That's comprehensively looking at the case and saying, hey, we could have done all of these things to help. Is there any evidence based intervention that could have been done prior? I already know one of the answers that you've thought of. So if anyone knows the answer, I want you to take a pause and think about it because we've already learned one way.
I talked about the Medicaid 1115 waiver, but screening for any of us that want to do some policy work or get involved in that, screening across the board has always been a hallmark for those that enter the criminal justice system. And I think most counties have done a good job, having worked in a few different states with that. They are identifying these patients early on. So making sure those questions are asked are going to be important, because most people aren't just going to come up and say, yeah, I used it, or yeah, I got this problem. So you have to really pointedly ask the question, and then using whatever available resources there are that can either closely treat whatever is going on and or has the most evidence. Even though FDA approved, there may be some support to get a little nuanced, if you will, in some treatments. But yeah, those would be the things that I think really collaborating or partnering before release. Folks get out, it's different. They even have some places where the pharmacy is right there before they exit the building, exit the jail. And some folks don't pick up that medication. They're not worried about that, right? And having that thing in hand, if you can at least hand it to them, you're at a better step than to say, go to the pharmacy right there. When the exit door is
Yeah.
right there, I'm not thinking about that. I ain't see my kids in a year. I want to go see my kids. I want to go
Yeah.
be with my wife. I ain't worried about whatever
Yeah.
he about to prescribe. That's just real. I can't even blame that person.
No, I definitely understand. That's not the first thing on their list of things to do when they've been in jail. And sometimes they were there for a really long time. They just want to go home. They're not even thinking about that. So
For sure.
that's absolutely true. Thank you so much for all of this education and knowledge. I have learned a few pearls myself. So I know we've done a few mini crash courses throughout, but there's still an opportunity if you would love and would like to. Any topic of choice from our discussion today or anything else that you felt like you would want to do a mini crash course and teach us, time to do that.
Yeah, a lot of things come to mind from what we talked about today. I think making sure that we ask the questions are going to be important. There's always some research that comes out, but a lot of what I've seen lately lies on the clinician's lack of comfortability to treat addiction. We all hope for the day that we can treat addiction and psychiatry or mainstream mental health under one roof where the person treating the schizophrenia or PTSD or ADHD doesn't then send the person somewhere else to get the addiction treatment. Even talking about the person leaving the carceral setting, not going to pick up that medication, sometimes going out of your office is the same thing, right? So making sure we're asking the right questions, both as it relates to substance use disorders and even we talked about the legal intersection. What does your past carceral or legal history look like? That can really help set some of the foundation. You see the patient, they always seem to be angry with you. It may not have nothing to do with you, but I mean, that perhaps sense of anger is what they've built over the years, being in an environment for 15 years and not having this court mandated treatment. I think about that. We talk some of the policy work, but don't give up if you can. And I having a team to not only bring about different lenses on some of these cases are good. We talked about the team members that can be involved, but also encouraging one another because some of these cases aren't easy and you'd be the last man standing, not giving up on this patient because there could be a better alternative. Asking them what they want is important. What do you want out of this? We need to have a heart to heart because they need to work alongside you. Sometimes we do got to pull them, but you can't pull everybody. So help me get you across the finish line you want to get across. Hopefully that's a mini course. Thank you for listening.
Yeah.
Yeah, our Drew University in Southern California has a medical school and a general psychiatry residency. We also offer child and adolescent fellowship, and we also offer addiction medicine. More to come. Stay tuned for that. It's been a pleasure, Dr. Owusu, speaking
Oh,
with you.
thank you so much. Thank you so much. If there's anything else you would love to plug, please go ahead. Yes, to Charles Drew. I have had the privilege of knowing Dr. Barrett and also meeting their PD. It's a great place. So if you're interested in psychiatry, please look into it. It's a great place to train.
Yes, plug to the current employer, Sharp Southern California Health and Rehabilitation Program. Dr. Barber started this organization in 1994, and they do fine work within the community. He's always hiring. So, yeah, please reach out. Yeah, I don't care where you are, come to Southern California. I made the move. It's well worth it.
Absolutely. Thank you so much for coming. As we close today, here's some key takeaways I want you to take from today's episode. Really make sure you're advocating. Speak up and make sure as you're speaking up, you're also listening to the people that you're caring for. We know that recent incarceration is a major risk factor to requiring proactive and evidence-based addiction care. We also know that there's still some gaps in the care that we can give. There's not enough FDA-approved medications for some addictions or substance use. For instance, as we saw in Andrea, cocaine use disorder. So please make sure you're doing the research. We need you all to do the research. If you're in the community, you're supporting through your organizations. If you're an advocate, make sure you're advocating. And if you're a community member, your vote is also your advocacy, right? Your vote can change if Medicaid is cut or not. So make sure you're actually exercising those rights that you have. If you're a student, this episode is really for you to think about if this is a field of interest, just be curious. Try to learn more, see how you could play a role. What are some areas that you could start learning from volunteering at community organizations, trying to observe a forensic psychiatrist or an addiction psychiatrist? If you're a policymaker, incarceration without treatment actually increases harm. And in the long run, it's costing you the money you're trying to save. So please make sure you're putting in place policies that are going to be helpful, not harmful. And if you're within the general public, relapse after incarceration is predictable, not really a moral failure. And we would hope that you would be a great support to your families, to your friends, and to yourself. A sign of reflection from our literature today is that incarceration may exacerbate rather than mitigate illicit drug use, especially among Black Americans. We appreciate you for coming in today to listen and to learn, and also to share with your friends, your families, and your colleagues. Thank you to our amazing guest, Dr. Barrett, who has been so gracious coming in so late today and then teaching us. Thank you to our listeners who week after week, you come here, you listen to me babble away, and you show our guests so much love when they come and they teach us, you learn, you let us know you're learning something. And the resources and the studies will always be linked below in the show notes. Join us next time. We have so much in store this season. We have so many people lined up, from harm reduction to Suboxone to just discussing different modalities of treatment and addiction. And in this season, we'll be expanding to other specialties beyond addiction. Thank you for listening. Stay ready, stay aware, and stay grounded.